Thank you so much, sir, for the kind introduction. So I would like to thank Dr. Kumarel, sir, and Recepta team for inviting me again to this prestigious conference. So it's always a tough task to follow Dr. Kumarel, sir. So he's our opening batsman today. I'm just following him. So my topic today is about youth onset type 2 diabetes, clinical approach. So we are seeing lots and lots of young type 2 diabetes. So it's becoming more and more blurry, because what was taught to us in medical college was type 2 diabetes always happens in elderly people who are obese, but now it's becoming more and more blurry, and we are seeing lots and lots of teenagers getting type 2 diabetes. So the assumption was type 1 diabetes usually happens in childhood and type 2 diabetes happens in late adulthood. And we have monogenic diabetes, which usually presents in childhood, but it gets picked up slightly later. But there is an overlapping period which happens during puberty, post-puberty stage, and before they reach their adulthood. And previously we assumed that most of these patients had type 1 diabetes or monogenic diabetes, but now we are seeing most of them are having type 2 diabetes. So there are new terminologies coming in, like early onset type 2 diabetes, young type 2 diabetes, and now we have this newer term called youth onset type 2 diabetes. This is predominantly for teenagers, adolescents and teenagers. They call them as youth onset diabetes, and early onset type 2 diabetes is an interesting term. We had a discussion, Dr. Vijay Bhaskar Reddy sir was telling me yesterday. I think for Western context, they take it as less than 35 or 40. In our country, we should take it as less than 25 because we are more obesogenic and also we are more insulin resistant. And the reason why I think 25 years was chosen by many specialists was only after age of 25, type 2 diabetes becomes more predominant, and before age of 25, it could be monogenic diabetes and other reasons for diabetes could happen. So that's the reason why it's important we classify them early. For my patients, for youth onset type 2 diabetes, there are two things we need to ensure. One is to ensure that they don't have type 1 diabetes because the management completely changes. So there are ways we can differentiate it. We'll look into that later. So for type 2 diabetes, one of the driving force is urbanization, change in lifestyle, and increasing in obesity. So this slide shows how industrialization has changed adult obesity and childhood obesity, and type 2 diabetes incidence follows suit. So when pre-industrial era, initial industrial revolution was happening, less number of people were obese, so less number of type 2 incidence was happening in adult population. As we went into an advanced industrial stage where we became less and less mobile and also the dietary patterns changed, more and more adults became obese and also type 2 incidence went up. Similarly, the childhood obesity is also following suit. So as the childhood obesity, as shown here by the darker line, as the childhood obesity goes up, the diabetes incidence, type 2 diabetes also goes up. And this is a world event, and India is also not left behind. This is more pronounced in developing countries more than the developed countries, especially for us Asians, because we are more insulin resistant. And this is data from our country where they looked at the prevalence of type 2 diabetes from age of 35, 30 or 25, and you will be surprised that there were about 17.9% of them had type 2 diabetes. And when they looked into those people with family history of diabetes, the prevalence was much higher. This is for more than 35, 40.1%. And if you look at less than 25, quarter of the population, when someone had a family history of type 2 diabetes, had diabetes in the prevalence was much higher. Puberty is one of the reasons why people develop diabetes after they're teenagers, because both men and both boys and girls, they go through puberty and it causes significant insulin resistance, and that's the reason why puberty unmasks insulin type 2 diabetes. And when young children put on rapid weight at that time, this makes them more prone for developing type 2 diabetes. So when someone is in an obesogenic environment and there is a genetic predisposition, especially with family history of diabetes, the childhood obesity goes up, and this, as Dr. Kumarel sir was telling, lots of ectopic fat deposition happens, especially when it happens in the pancreas. It leads on to insulin resistance and decline in beta cell function. And during the pubertal insulin resistance, if the child puts on weight, once again it worsens this beta cell resistance and causes significant decline in the beta cell reserve and its functionality as well. So there are lots of reasons why we are seeing a significant increase in the childhood obesity and youth onset diabetes. The main thing is change in lifestyle. So we moved on from having a healthy diet to ultra processed food, moved on from having an active lifestyle to a couch lifestyle now. And they have excellent data that in indigenous population, when they followed the Western diet and Western lifestyle, there was increased prevalence of obesity and type 2 diabetes. They looked at two indigenous population, and the first group, Odam group, and they compared it with Pima Badger group, and they found that this, where they followed the Western population, Western diet, they had increased incidence of type 2 diabetes. Whereas this group, when they continued to have the old style of their lifestyle, there was no increase in type 2 diabetes. And as Sir said, ectopic fats plays a major role, and when there is fat in the liver, once again insulin resistance goes up, and as the beta cell function declines, the hyperglycemia worsens. And maternal exposure of hyperglycemia to the babies also plays a major role. We'll look into that a little later. And lots of environmental factors like pollutants, plastics, sleep deprivation also plays a major role. And we Asians are having less lean mass, so we are more prone for insulin resistance. That's another reason why more and more young people in our country are developing type 2 diabetes. So why should we care? In US, apparently they have more than 5,000 new cases every year, and there is a 3-time more higher prevalence as during the late teenagers compared to early teenagers. And the main worry is these people already have complications at the time of diagnosis, and they also rapidly progress towards getting microvascular complications predominantly, and eventually they'll get macrovascular complications, and their lifespan might decrease because of early onset of this hyperglycemic exposure to their body. That's the reason why we need to catch them early. So one of the main pointers towards having youth onset type 2 diabetes is they usually have a very strong family history, and they have a severe metabolic problems which happens usually. Lots of times it could be just an incidental hyperglycemia. Sometimes they can present with ketoacidosis or even present with HHS state in a reduced GCS state as well. So the diagnostic criteria for youth onset type 2 diabetes mirrors what we normally follow for type 2 diabetes, having a fasting glucose more than 126 or 2 hours OGTT of more than 200 or a random blood glucose more than 200 with hyperglycemic symptoms, or a HbA1c from a reliable lab of more than 6.5%. So normally, when someone is asymptomatic, we repeat the results again. Usually if it's just a random sugar or if it's HbA1c alone, then we tend to repeat it again. But if it's an OGTT, even a single test should be sufficient. So anyone with this hyperglycemia, whether it's type 1 or type 2, will have the same criteria. So it's very important that we differentiate. So these are the various reasons why a young person, an adolescent person, or a late teen might have a diabetes hyperglycemia. So it could be type 1 diabetes, type 2, rarely it could be monogenic diabetes. If someone is pregnant, it could be a gestational diabetes, and there are other reasons why they can develop like secondary diabetes due to pancreatic problems like FCDP or FCPD, or diabetes secondary to endocrinopathies like Cushing syndrome or acromegaly, or it could be drug-induced diabetes from steroids as well. So this is a busy slide. I would like to thank Dr. Vijay Reddy sir for giving me this. So when someone presents to us with diabetes, it's very important that we ask for family history of diabetes. Usually for type 2 diabetes, there is a strong family history, and for monogenic diabetes, there is a very strong family history of diabetes. Usually there's more than 3 generations. And usually they'll have, for monogenic diabetes, the ketonuria will be negative, and C-peptide is usually good. They're very responsive to sulfonylurea. But if the family history is not that much like 3 generations, usually it's type 2 diabetes. Sometimes they may not have any family history as well. Usually C-peptide is very good for them. And ketones are usually negative, but sometimes even youth onset type 2 diabetes, they can present with DKA as well. When ketones are positive, we look out for C-peptides, and if C-peptide is absent, normally we classify it as type 1 diabetes. And if ketonuria is negative with the negative family history, And if we note that the C-peptide is poor, then we go for an abdominal X-ray. If there is a pancreatic alkali, then we feel that mostly it's going to be a diagnosis of FCPD, and then we look out for the other rare causes. So there are two things which helps us differentiate. One is C-peptide, and other one is autoantibodies. But the caveat here is C-peptides, even in type 1 diabetes during the early stages, because of the honeymoon phase, it might be present. And in an acute hyperglycemic crisis, C-peptides can be negative as well at some points as well. So we can't just go through just an isolated C-peptide level. It's ideally done when someone is stable, not when they're acutely unwell. And then usually for type 1 diabetes, we tend to do it 2 to 3 years after the diagnosis, not at the initial phase itself. So it's not all or none, but this is a very useful flowchart to help us. And autoantibodies are very useful to differentiate type 1 diabetes and type 2 diabetes in most of the patients. Normally we look out for anti-GAD antibodies and anti-IA2 antibodies. So this is another good slide to differentiate what are the various reasons why youth onset diabetes might have. For type 1, as I said, normally people will have C-peptide levels being low after 2 to 3 years of diagnosis, and islet antibodies are usually present. For type 2 diabetes, usually the C-peptide levels are quite high, and antibodies are usually absent. In monogenic diabetes, it follows the same rule as well. So should we screen everyone? So unlike adults, this doesn't happen to all the obese individuals or obese adolescents. So normally they have high risk risk stratification to identify those patients whom we need to be screening. Normally we need to ideally screen anyone who's overweight or obese and have one or more additional these risk factors. Either they have maternal history of diabetes or the baby was born with GDM mother, when the mother had GDM, and strong family history of type 2 diabetes. And for Western population, they look at race and ethnicity and signs of insulin resistance like acanthosis nigricans and polycystic ovarian disease or small for gestational age at birth. Those things tells us that they're at a very high risk, and normally they should be started screening after puberty or at 10 years of age, whichever occurs earlier. And one of the worrying things about youth onset diabetes is there is a rapid decline in the beta cell function. So this is an interesting slide comparing adults and youth onset type 2 diabetes and the beta cell function. So this is showing how much insulin being secreted, and this is looking at the insulin sensitivity. So the insulin sensitivity, the higher the number, better it is. And this insulin secretion tells us about the beta cell reserve. And you can clearly see that in youth population, they are having very high insulin secretion from the beginning, but the insulin sensitivity is much lower to start with. And the decline of the insulin secretion is much more rapid compared to the adult population. And this is looking at the intervention at 12 and 15 months. The green one is for glargine and metformin, and the red one is for metformin alone. And you can clearly see for in adults, when they were introduced to insulin at diagnosis, the decline was slightly lesser. The insulin secretion got better. The sensitivity also improved slightly. Whereas here, the insulin secretion also deteriorated over a period of time. But what's interesting is the sensitivity did not improve, whether they were on insulin or metformin. So there is a rapid decline with no improvement when therapies were given for their beta cell sensitivity and the beta cell function deterioration. So in youth onset diabetes, they noted people have severe insulin resistance. This has been proven with all the studies. They have early beta cell failure because the beta cells are working hard from the beginning and it deteriorates very quickly. And because they've been exposed to high glucose levels for a long time, they're at more risk for developing complications, whether it could be macrovascular complications like cardiovascular disease and other things, or microvascular complications and other metabolic syndromes like NAFLD, hypertension, dyslipidemia, and OSA. This is because they've been exposed to hyperglycemia for a long time and lots of interplay happening between chronic inflammation and oxidative stress leading on to complications. And unfortunately, lots of times at diagnosis itself, damage has happened, especially microvascular complications. So in one of the studies, they showed that at diagnosis, 14% of them had BP more than 95th centile for that age. 13% microalbuminuria was at enrollment. and 80% of them had low HDL and 10% of them had high triglycerides, suggesting that they already had metabolic syndrome active in them. So this is the reason why we need to catch them early and also be aggressive if possible, prevent them from even entering into the stage. And the microvascular complications are noted to be happening very quickly, and it deteriorates very quickly in the next 10 years itself. The prevalence of retinopathy, nephropathy, and neuropathy are far higher compared to even type 1 diabetes. I'll show it in the next slide. And they also develop metabolic complications like hypertension, dyslipidemia, cardiovascular disease, MASLD, orthopedic complications, and cholelithiasis. And rarely they can develop DVT as well because of the hyperglycemia and obesity. And obviously this has a deep psychosocial impact. People get lots of anxiety and depression and psychological burden because of these problems. So it's very important that we overcome this. So this is an interesting slide which compares the complication for type 1 and type 2 diabetes for similar aged people. And in young onset diabetes, they noted that the macrovascular complications at diagnosis was not that different. The hypertension, cardiovascular autonomic neuropathy, or arterial stiffness was not different between type 1 and type 2, whereas the microvascular complication rate was much higher, even at a younger age. So usually for screening for type 1 diabetes, we tell them they can start screening for retinopathy and nephropathy 5 years after diagnosis. For these people, youth onset type 2 diabetes, we advise them to start screening at diagnosis and every year after that, because lots of times the damage has already happened at diagnosis itself. And reproductive issues also plays a major role because lots of young girls who are enrolled in various studies became pregnant during the trials, and this is what we'll also see. So when someone becomes pregnant, and if they have hyperglycemia, whether it's gestational diabetes or already existing diabetes, if it worsens, it not only affects the mother and the mother alone or the fetal outcome at that time, it's also going to play a major role for the baby's future as well, because the baby is going to be exposed to hyperglycemia during the fetal life itself. This causes epigenetic changes. This leads on to a birth weight. Baby can be low for gestational age, or it can be obese as well if there is uncontrolled diabetes, and it can cause childhood obesity. It can cause early life growth and health and development changes. And this causes significant difference to the way beta cell functions, adiposity, inflammation happening. And this is one of the reasons why there is increased evidence of youth onset type 2 diabetes. And this circle is going to get worse and worse. So it's very important that we break this cycle as early as possible. So the main way to manage youth onset type 2 diabetes is offering them a holistic care. So not only we need to offer a good glycemic control, we need to ensure that the complications or risk is also reduced, especially microvascular complications and cardiovascular risk reduction from the beginning. Weight needs to be managed from the beginning, and we need to ensure that they get adequate psychosocial support as well. Communication is very important, and we need to ensure we get aggressive therapy from the beginning. And this is a very simplistic way of looking at the management. So early aggressive glucose monitoring and adjusting the therapy as per the glucose control, whether it was structured SMPG monitoring or having HbA1c every third month to ensure that they have adequate control, is important. And lifestyle intervention plays a major role. Even for adults, it's very difficult to follow a good lifestyle. You can imagine the plight of teenagers and young adults going through this. But it's very important that we keep emphasizing it every time. Studies have shown that there is only a moderate benefit, probably because of poor adherence. So we need to ensure that this is ingrained into them from the beginning to avoid excess weight gain and follow a healthy diet like Dr. Kumaravel said, and have adequate physical activity from the beginning. Pharmacotherapy, unfortunately, this age group, we don't have many trials to look into it. Predominantly, the recommended therapies are insulin and metformin alone. Now, GLP-1 analogs like dulaglutide, liraglutide has been got the FDA approval to be used in this age group, and they are looking into oral semaglutide. They are doing a study now, Pioneer Teams trial for looking into usage of oral semaglutide in this age group as well. Few of the SGLT2 inhibitors, both dapagliflozin and empagliflozin, has been recently approved by FDA for using for diabetes management. They cause significant HbA1c reduction, but they don't cause any change to their body weight at that age group. Because of the potential of preventing the complication, I think the early usage of SGLT2 inhibitors has been recommended. I think GLP-1 is going to be the future treatment management strategy for this group. The reason being, it not only offers a good glycemic control, weight reduction is going to be there, sustained weight reduction is going to be there, and also metabolic complications are going to be reduced. Bariatric surgery also plays a major role, especially if someone is having a BMI of more than 35, but it needs to be done with proper support and motivated individuals, because it's no use doing a surgery and then if they're not followed up, they're going to regain the weight what has been given, but it's one of the most effective therapies for this age group. So we don't have many interventions in this high-risk individual. That's the most worrying thing, but things are shifting. I'm just going to skip this slide. So to conclude, youth onset diabetes is a unique form of diabetes with rising incidence, which rapidly progresses with beta cell destruction and beta cell dysfunction, and there is a high complication rate, predominantly microvascular complication, but macrovascular complications will also follow suit. We need to develop new models of care which will more effectively engage the youth with type 2 diabetes and holistically improve their well-being and mental health. Managing youth onset type 2 diabetes and mitigating the risk for micro and macrovascular complications requires development of a more effective interventions as well as strategies to overcome the barriers of adherence, which is typically encountered in the younger group, because lots of times these young children don't turn up for clinic appointments after that. The parents are very reluctant to start therapy because it's at a very young age. Fortunately, there is lots and lots of effort being put in. So this is a publication last year from Diabetes Care, which is the major journal from American Diabetes Association. They showed what NADDK, which stands for National Institute of Diabetes, Digestive and Kidney, they have done with multiple trials for youth onset type 2 diabetes, and they're doing another trial as well. So they are looking into it, but I think more effort needs to be put in to overcome the complications faced by this group. Thank you so much for the opportunity.